Următorul panel de discuții, Nutrition Guide for Clinicians, Dr. Golnar Raissi, medic nutritionist în Medical Nutrition and Behavioral Health USA. Dr. Raissi, thank you so much.
Good morning, everyone. Thank you very much for inviting us to come and talk about cystic fibrosis. My talk is about nutrition and bone health in cystic fibrosis. So what I want you to learn from this lecture today is to learn about the bone disease in cystic fibrosis, how to detect it, how to prevent it, and the importance of physical activity, as the gentleman mentioned about the importance of physical activity. So just a quick summary. Cystic fibrosis is a multi-organ disease, autosomal recessive disorder, 40,000 people in the US, more than 100,000 worldwide, and it can happen in any race and any ethnicity. So as you can see here, it affects the pancreas, the skin, the lungs, liver, intestine, reproductive system, and I'll be focusing on the bone later. Just a quick review just a quick review on the weight goals. Between the age of 0 to 2, 50% of weight for length is important. Then from age 2 to 20 is 50% of the BMI. And we use WHO, World Health Organization growth chart between age 0 to 2, and we use the CDC growth chart between 2 to 20. And in female, we like the BMI to be more than 22, and for men, more than 23. And this has not changed even with the new modulators. Okay, the importance of micronutrients. You know, the micronutrients are the fat, the protein, the carbohydrates. So what we need is, because of the high energy need to increase energy expenditure and increase losses from malabsorption, we recommend the protein and the calorie to be more than 1.5 to 2 times the recommended daily allowance per day. This is very important because with the new modulators, we're talking about calorie requirement. We still talk about calorie requirements because of the malabsorption. Because if there is any cystic fibrosis related diabetes, if there are the severity of lung disease, the infection and inflammation, but the calorie that we need right now, I mean, I'm talking for patients that are eligible for modulators, healthier calories. We used to talk about lots of butter, cream, lots of fat in food. Now we're talking about more olive oil, avocados. I'm not sure if avocado is part of your daily diet. We talk about lean meat, more chicken, fish. If you're having red meat, make sure it's a lean red meat. So calorie is still very important part of daily diet. Okay. Cystic fibrosis related bone disease. Bone disease is an important comorbidities of CF, along with cystic fibrosis related diabetes. So the chronic infection, pancreatic insufficiency, the nutrition and low BMI, low vitamin D, inflammation, decreased physical activity, all of that has direct effect on the bone disease. We know that the CFTR dysfunction and deficiency is associated with a reduced bone density. And if you pay attention here, so this is the bone reabsorption, and this is the bone formation. I guess this is not working. You see that? Yes. The bone formation. So for bone formation, we need the estrogen, we need insulin, we need testosterone, we need the sex hormones. And the bone reabsorption, the corticosteroids that we use daily, the inflammation and infection, IL-6, these are the ones that can cause the bone reabsorption. So it's very important, the daily treatment, how it affects our bone health. Bone modeling. The maximum bone mass is achieved, as you can see here, around age 20 to 30. You know what? The genetics, the body size, the weight, the nutrition, the sex hormones, and the weight-bearing exercises has such an effect on the bone modeling. And the prevalence of bone disease, as you can see, it grows with the age. Age between 30 to 40 is the maximum of the prevalence of the bone disease. Here in this study, it shows that the bone mineral. So bone is made of mineral, right? So the low bone mineral density reported in up to 30% of children and adults with CF. And the prevalence increases with age. Look at the age 12, 8 to 12, under 8. So the prevalence of low bone mineral is higher when the age is above 12. The bone fracture. The first column is here are the patients with CF. This is the healthy population, right? So if you can look at the male between age 25 to 45 years. So the fracture per 100 patients, this was the study, it's higher with CF than the regular population. Female, age between 17 to 34, it's higher, 3.70 to 1, and it continues. So the fracture increases because of that low bone mineral density. The prevalence of bone disease in children and adolescents is between 13 to 34%, with higher incidence, and non-vertebral and vertebral fraction is up to 27%. Okay. So what's important here? Being at healthy weight puts load on the bone and maintains the muscle mass for normal physical activity. So the short stature and low muscle mass have been established as a major contributors to reduce bone mineral density. So optimization of the growth and nutrition is really the major determinants of bone mass. How do we increase the bone disease in our clinic? Well, we look at first of all, when the patients come, we look at their nutritional status. We talk about calcium, we talk about vitamin D. We do the annual test for the fat-absorbed vitamins. We talk about if they're taking any other vitamins. We talk about their physical activities. And we discuss the steroid use. to see if this puts them on a higher risk for bone disease. Besides taking, besides looking at these elements and nutrition, we ordered DEXA. DEXA is a dual energy X-ray. So the parents usually get nervous as soon as you talk about DEXA. They think it has more radiation. But if you just look at here on this, the bone radiation, the DEXA has a less radiation than a chest X-ray and CAT scan. Even if you get on the plane and go cross country, this is in America, the radiation is less. So this is really the golden standard for bone disease. And it can be used to measure body composition, the body fat, and lean muscle mass. When we order the bone density test, the DEXA, for children, we basically measure the whole body minus the head. So the sides that are preferred over the hip is usually measured in adults because of the rapid changes in geometry during the growth and puberty, so we don't really focus on that in children. We order the whole body without the head. And there are limitations. Basically, one of the limitations with DEXA is, for children, you have to calibrate for the child size. So that becomes very difficult. So we cannot do this, right? So we have had, patients that are kids, and they've used the adult standard for them. So what do you get? You get osteoporosis in children. And, it changes the whole treatment. So that's not correct. So DEXA, the machine has to be calibrated for the size and the weight of children. As we have the same thing in blood work, you have different numbers, you have different, for example, you have upper limit, lower limit with vitamins. When it comes to DEXA, we have Z-score, T-score. It gives numbers. Z-score we use for children, T-scores we use for adult. And according to that number, the endocrinologist can adjust either pharmaceutical agents, non-pharmaceutical agents, and then talk about other vitamins. And then when to avoid DEXA scan is usually pregnancy, if there has been a gastrointestinal contrast, if the patient have any devices, and the inability to remain still or attain correct position. Okay. So this is very important guideline that was made in 2005 with the Cystic Fibrosis Foundation in America, 2008 the French, and 2011 the European. So when do we order this, bone density? When do we examine this? Well, we examine the bone health from young age. But in America, after age 8 or 18, we look at any of the risks. If we see that the FEV1, the spirometry is below 50, if the BMI is low, if there has been a lot of use of steroid, more than 90 days, if there is a history of delayed puberty, then that's the time that we order DEXA. But the French are more aggressive because right at age 8, they start doing that. And the European guideline, age 8 to 10. And if you notice with the French guideline, if the scores for children and an adult are not optimal, they start ordering this every 2 years or even every year. But in America, we do it every 2 to 4 years or every 5 years. So the French are more aggressive in treating bone disease. Okay, so now how do we prevent or how do we treat this? Calcium and vitamin K is very important. But let me talk about calcium first. Calcium is the most abundant mineral in the whole body, the bone, the teeth. A lot of neurotransmitters need calcium to be able to function for the transport of albumin. And we know that the extra daily calcium is excreted through the gut or through the urine. So serum calcium is not a useful indicator of how much calcium we take daily. The deficiency of calcium in CF is multiple factors because of the malabsorption, maybe malnutrition, because of the increased intestinal permeability, the increased urinary calcium excretion as a result of high salt diet, vitamin D deficiency, and the less fortified food with calcium can cause the deficiency in CF patients. The drug-nutrition interaction with use of corticosteroid can increase the calcium need. If the patients are on levothyroxine for thyroid, that calcium reduces the absorption of the drug, so it has to be at least 4 hours apart of calcium supplement. So these are the things that you really have to pay attention. And there are other medication here too, in the list. How do we choose the calcium? Well, there are different forms of calcium, but first we want the calcium to be taken in the diet. That is very important. If the food is fortified from calcium, like the milk, the cheese, the cream, unless you have allergy to dairy or cannot use dairy, but we rather you take it from food. Like in America, we have a lot of food fortified with calcium. There are different forms of calcium, from the citrate, carbonate, phosphate, and lactate. We usually recommend the calcium citrate, and because it does not need the acid for absorption. But see, this recommendation of calcium, it really comes after we see you fill out the diet diary for us. That is very important to access that diet diary for a couple of days so we know how much calcium you take. And then based on that, and based on low vitamin D, we can recommend the amount of calcium citrate in the diet to be taken every day. And of course, age appropriate. Vitamin D deficiency is so important. Vitamin D is one of the fat-absorbed vitamins that is lacking in cystic fibrosis, decreased fat stores, because of the suboptimal intake of vitamin D containing food and supplement. We know that we get vitamin D through the sun, our skin goes through our GI system, through kidney and liver at the end. So, for example, this time of the year, it's really good to be supplemented with vitamin D. But how do we supplement? Well, this is the guideline, right? This is a guideline that the CF has put for minimum daily intake. But that really depends on the individual. When we do the blood work, if there is any deficiency, then we adjust to that. We have put patients on 5,000, on 10,000 daily with meal and their enzymes. The toxicity from vitamin D is very rare unless you take, 100 to 200,000 per day for a long time. Otherwise, toxicity from vitamin D is not very common. And the vitamin D, I'm sure you use the same thing. We use the D25OH in the annual blood work. And if it's low, we supplement the patients and we remeasure within 3 months. Vitamin K. Vitamin K, along with calcium and vitamin D, is very important to use for the the deficiency of vitamin K can cause osteocalcin, so that is so important to know the correct dosage. In America, we have it in we call it ADEC, the ADEK in a bottle. Usually it's all measured. But if you don't have that in Romania, you can, get it individually and use this amount per day. But again, that depends on how much your doctor is going to prescribe, if they do the blood work and if they see that it's high and low in the regular blood work. Physical activity is very, very important. Dr. Sadeghi talked about it. The gentleman talked about physical activity because we know that the muscle mass and strength increases during the growth and puberty. So we're talking about, from teenage years to age 20 to 25, that this is a very crucial time to increase the mechanical load on the bone by increasing the muscle mass, because that eventually puts a positive change in the dimension and strength of the bone. So physical therapy, right now we have physical therapy in our team, which, beside, teaching, how to do the lung clearance, it's very important to teach you the physical education, the exercise that you need to do. Because let's say, we do the DEXA, you come back with having thinning of the bone, osteopenia, or even osteoporosis. So what happens? There are exercises, there are sports that you cannot do. So your physician, along with the physical therapy, they have to come up with a whole plan for patients, how to use the daily exercise, how to compliant with that. And especially we always talk about weight-bearing exercise for our bone. But again, that depends on if there is any osteopenia, if there is any thinning of the bone that has been picked up on DEXA. We talked about the pancreatic insufficiency, low BMI, vitamin deficiency, calcium deficiency. We talked about the importance of making sure that the sex hormones and the sex hormone, delayed of puberty, use of glucosteroids during the chronic infection and inflammation, the decrease of physical activity. And a physician talked about celiac disease yesterday. That all can have an effect on the bone disease. Because again, as I mentioned earlier, bone disease is a very important comorbidity in CF, along with CFRD. So we have to make sure that, if the patient comes with osteopenia or thinning of the bone, we have to make sure if there is any underlying of CFRD, celiac disease, talk to the physician how to manage the daily use of oral and inhaled steroids. And if there is any question, I'm ready to answer.
Mulțumim, thank you so much, mulțumim. Întrebări, orice întrebări, lămuriri. Vă rog.
Thank you very much for your talk. I just want to ask you if you find a very low level of vitamin D in a child or a teenager, how high do you go with the doses to treat this and for how long?
Yes, we have seen very low numbers. We have seen, because you know that the ranges that we have is usually between 30 to 60, right? Do you have the same range here? Yeah. Yes. So between 30 to 60 is the range we have. We have seen as low as 8, as low as 5, right? So what we do is, there are some endocrinologists, they put the patients on, or the pulmonologists, they put the patient on 50,000 per week, right? We don't do that. Now we're saying that it's better to have 10,000 every day because of the better absorption than just a one bolus of 50,000 one day, right? So we go for 10,000, we remeasure within 3 months. We haven't done more than 10,000 per day, or I haven't yet, exactly. So 10,000 per day, days a week, 70,000. So, and then we remeasure in 3 months. If the numbers are still low, usually it should come up, right? If the patient is compliant, if they're taking with the food and enzyme, right? If the numbers are still low, then we continue again. Because as I said, we haven't, at least in our center, we have not seen any liver toxicity unless, you put them on mega doses. Do you do the same thing here too?
Yes. Yes, we do. Maybe we didn't use 10,000, but 6 or 8 or 5, depends to the level the patient has. I have many patients with low vitamin D. There are also very sick patients and with moderate to severe lung disease. And it's also difficult to check their compliance, how they are taking. They are poor families, they don't understand very much, but usually in these patients we see this. In patients that take care of their health in general and have good nutrition and are not so sick in their lungs, the levels are good.
So for those patients that they are very sick and they have low vitamin D level and their age is above 8, then you definitely have to order the DEXA, right? Because if the diet is not good, probably they're not taking enough calcium too, right?
Yeah, we see also low calcium levels in these patients. Yeah.
So I'm sure that you'll be surprised to see how many osteopenia that you might see.
I'm sure
in
of
children,
that.
right?
Yeah.
And then how do we, because let's say with the modulators now they're seeing the improvement, right? There hasn't been much of a, they are doing a lot of investigation and studies. And with the osteopenia in children, they are using, different pharmaceutical agents. But that really depends on the endocrinologist, how they want to manage that. Because, there are the side effects of those, agents too, right? And that's why, bone disease is becoming one of the major comorbidities of CF, with the prolonged aging now, right?
Yeah, thank you.
Sure.
Alte întrebări, vă rog?
So we saw the list of proteins, carbohydrates, and fat. But what about the fibers, especially in the case of the transit and the hard stool or constipation in case of CF?
Exactly. See, the protein, the fat, and carbohydrates are the macronutrients that is so necessary to have in their daily diet, right? And it has to be higher than average because of, the way that they breathe. And we just want to make sure that they are, they have a good BMI, so just in case if they get sick and all that. Fiber is very important too. We don't see now with the new modulators, we are encouraging more fibers, of course, right? Because now the CFTR modulators are fixing the underlying cause, right? So we want the same thing, that for a healthy diet of fiber for regular people, right? But if you fix we ask for, of course, fruits and vegetables, but because I'm talking about children. The stomach is small in children, and they swallow their sputum all the time, right? So we rather the patients to have the protein and the healthy fat and carbohydrates rather than a lot of vegetables and fruits for fiber. So fiber is great for constipation, but if there is constipation, then we have to recheck the enzyme dose and see what exactly is happening, right? So that's why it hasn't been a lot of talk about fibers with CF. But I'm sure that with modulators, things will definitely change.
Am și o întrebare referitor la... O întrebare referitor la inflamație intestinală. Dacă este ea specifică fibrozei chistice sau în momentul în care ne confruntăm cu o creștere a calprotectinei, ne putem gândi la o boală inflamatorie intestinală, Mă refer aici la o creștere a calprotectinei destul de rar, de 4 ori de curs de 6 ani, fără alte simptome și cu celelalte analize în parametrii normali. Deci, este inflamație intestinală o componentă sau o problemă în fibroza chistică sau poate avea legătură cu dozarea de enzime sau trebuie să mergem pe pista unei boli inflamatorii intestinale. Mulțumesc frumos!
So calprotectin is an inflammatory marker, right? So if that is high, then we have to look for underlying cause of what's happening in the GI system. So that's the time that, yes, is the enzyme dosing important? Yes, it is important. But that's independent, you know, that calprotectin is independent from the enzyme dosing. So definitely a GI has to intervene here. Is it celiac disease? Is it other GI problems? So that is very important that the GI has to, you know, to look into this. It is an inflammation. It is a lot of course, a lot of inflammation as we see that with CF and the GI, right? But that particularly when the calprotectin is high, they have to detect that. We can't just say, oh, let's just, you know, fix the dose of enzyme. That has something underlying cause. And now we know that, you know, the celiac disease is happening with CF population, even as a child, not just an adult. I hope I could answer your question.
Mulțumim foarte mult, doamne dr. Golnar Raissi, medic nutriționist. Yes, we also have a appreciation diploma for you. Thank you kindly.
Thank you very, very much.
Mulțumim.